Kollam President Dr. Lakshmi Priya, Secretary Dr. Anish, Chief Guest of the Day Dr. Sujit. ആദ്യമായി തന്നെ ഡോക്ടർ സുജിത്തിന് എല്ലാവിധ ഭാവങ്ങളും നേരുന്നു. അദ്ദേഹം ചവറയുടെ ശബ്ദമായി, കൊല്ലത്തിന് ശബ്ദമായി, അതുപോലെ തന്നെ എവയുടെയും ശബ്ദമായിട്ട് നമ്മുടെ നിയമസഭയിൽ ഉണ്ടാവട്ടെ. അദ്ദേഹത്തിന് എല്ലാവിധ ആശംസകളും ഭാവങ്ങളും നേരുന്നു. Coming to my topic, respected seniors and my dear colleagues, indeed it is a very honorable experience to receive the invitation from Dr. Rashmi Priya and to give me the opportunity to present this topic, approach to a patient with headache today. So the most defining moment in clinical practice is when you make the diagnosis, because once you make the diagnosis, everything else falls into place. The treatment part follows based on your guidelines and protocols. But the most important aspect is to make the right diagnosis. Headache is one of the commonest symptoms with which a patient approaches a clinician across specialties. So it is possible that a patient reaches an ENT surgeon first and he gets a diagnosis of sinusitis and is prescribed antibiotics, decongestants, and antihistaminics. If he visits an ophthalmologist, most likely he'll be diagnosed with a refractive error and would be prescribed a pair of glasses. If he visits a psychiatrist, he'll be taking lifelong medications, antipsychotic medications. So basically, what I mean to say is that the diagnosis basically
Praveen ji, make it full screen, then only it will move.
Full screen ആണല്ലോ. Okay.
ഇല്ല, full screen അല്ലേ ഇപ്പോഴും. Slide show ഇടുക.
Share screen stop ചെയ്യാം.
സ്റ്റോപ്പ് ചെയ്യണം.
സ്റ്റോപ്പ് ചെയ്തിട്ട് ഫുൾ സ്ക്രീൻ ആക്കിയ ശേഷം ഷെയർ ചെയ്യും. ഡെസ്ക്ടോപ്പിൽ ഓപ്പൺ ചെയ്ത് വയ്ക്കാം. മിനിമൈസ് ചെയ്യാം. സൂമിന്റെ മിനിമൈസ് ചെയ്യാം.
കാണാമോ സ്ക്രീൻ?
ഷെയർ ആയില്ല.
സ്ക്രീൻ ഇപ്പൊ കാണാമോ?
ഷെയർ സ്ക്രീൻ ചെയ്തു.
ആയോ?
ഷെയർ സ്ക്രീൻ
കാണാമോ?
ഇല്ല സാറേ.
Headache Society proposed, the International Headache Society proposed the International Classification of Headache Disorders first in the year 1988. Subsequently, it was revised twice, and presently we follow the ICSD-3 guidelines proposed in the year 2018. So basically, it is divided into three. Headaches are divided into three types. One, the primary headaches, which are distinct clinical entities and not any symptom of any underlying disorder. Secondly, there are secondary headaches, which are symptoms of any underlying basic underlying problem. And the third one is the painful cranial difficulties and other facial pains. Now, basically, the ICSD coding system consists of about 4 to 5 digits, and the system is hierarchical, meaning the first digit stands for the main diagnosis and subsequent digits refer to the sub-classification of the main type. For example, item number 1 is migraine, 1.1 is migraine without aura, and like that, familial hemiplegic migraine is 1, 2, 3, 1. So it is a hierarchical system wherein the first digit expresses the main diagnosis and subsequent digits represent the subtypes of the main type. So in this presentation, basically I would be covering how to take a detailed history with respect to headache in a case in a patient. And I'll be just touching on other topics like primary headaches, secondary headaches, diagnostic alarms, a few interesting cases, and at the end, a quick recap and summary. Hope I can enlighten you at the end of this presentation. So history taking is the most important tool to making a diagnosis in a case of headache. So you need to lend a patient hearing to the patient and listen to what he has to say. You need to ask the right questions and elicit the right answers from the patient. And you need to believe the patient, because what he says might not be scientifically explainable, or it may appear very funny. For example, a patient might say that his headache started after wearing a mask, or after wearing a helmet, or after a new hairstyle. All these things are possible. So we need to you take a detailed history and believe the patient and listen to each and every point that he's trying to describe. It is often said that if you don't have a diagnosis at the end of your history taking, you are unlikely to have one at the end of your examination or investigation. So coming to the details of the history taking, the first question you ask the patient is, how long have you been suffering from this headache? If the answer is more than 2 years, you can rest assured you are dealing with a primary headache and not a sinister one. Then you ask him, if you have been suffering from headache for so long, what brings you today? Is it because the headache has worsened, or is there a change in character of the headache? Then you ask him, when did he first have his headache? How did it start and how did it progress? In case of migraine, the onset of headache is usually in the teenage years, whereas in case of tension type headache, it usually starts a bit later in the 20s and 30s. If you have a patient who has never had a headache in his early childhood or adolescent life, but has a severe headache after the age of 50 years, you need to be cautious. You may be dealing with an Icsd. Sometimes the patient may be able to tell you an exact date of beginning of his headache. Right from day one, the headache has been so severe and has persisted for more than 3 months. It points to a diagnosis of new daily persistent type of headache. Then the location of the headache. All of us know sinus headaches are referred to the forehead and the malar region. Cluster headaches are usually felt around the eye and the temporal region. Tension type headache is felt as a squeezing band around the scalp. And migraine headaches are usually unilateral and throbbing in type, associated with visual and other changes. Now coming to the type of and quality of the headache. Is it pulsating or throbbing type, usually seen in migraine headache? Or is it like a series of stabs, or a severe stabbing type of headache, which may be felt as a single stab, multiple stabs, or a sawtooth pattern wherein you have multiple stabs without any relaxation in between? This is usually seen in case of trigeminal autonomic cephalalgias. Then you have the aching or pressing type of headache, as in case of tension type headache. Then if you have a lightning or excruciating type of pain, usually it points towards a neuralgic cause. Then you ask the patient about the intensity of the headache. Is it mild, moderate, or severe? If it does not interfere with his daily activities, it can be classified as mild. If it causes mild or some restriction of his daily activities, it is moderate headache. And if the patient has a headache which is so severe that he cannot perform his daily duties, it is classified as severe headache. Then how long has the headache, what's the duration of the headache? Does it last for seconds, minutes, hours, or days? All these points are very important, as you will find out in the subsequent slides. It is possible that the patient might have different types of headaches. So it is very important to ask the patient how many different types of headache he has got, and the frequency. Is it 1 per month, or between 1 to 14 days per month, or more than 15 days per month? So all these numbers have got significance, as we will find out in later slides. What about the periodicity? Is it continuous pain, as you have in chronic tension type headache, or new daily persistent headache, or chronic post-traumatic headache, or medication overuse headache? If it is episodic, it is usually seen in case of migrainous headache, or episodic tension type headache, cluster headache, and other types of trigeminal autonomic cephalalgias. And how exactly he feels in between attacks. Is he completely normal, or does he have interictal symptoms as well? And if the patient has remissions in between, what is the duration of the remission? Is it hours, days, or months? What are the associated symptoms? If it is associated with nausea, vomiting, photophobia, phonophobia, all these things points towards migraine as the cause of headache. And other associated features like redness of the eye, excessive watering from the eyes, excessive sweating, nasal congestion, or change in the personality or behavior pattern of the patient, or associated with speech and language pattern of the patient, all these points towards a trigeminal autonomic cephalalgias. Now, what exactly are the triggers? Does exposure to sunlight cause headache, or ingestion of food like chocolates, milk products, or nuts trigger a headache, or travel triggers a headache, or stress of exams or other tensions triggers headache? All these points are very important. And what exactly are the aggravating factors? Does skipping a meal or the menstrual period aggravate the headache? And what are the relieving factors? Is it relieved by sleep, or does the patient have to take medications for relief? Then what about the diurnal variation? Nocturnal headaches are usually a feature of cluster headache. And what exactly is the sleep pattern of the patient? Is he getting good sleep, or is there a delay in getting sleep, or arousals in between, or early morning headache associated with vomiting, which disturbs the patient during sleep? All these points towards an Icsd. And last but not the least, family history is very important. Now, coming to primary headaches, there are 4 types of primary headaches described. One, migraine, tension type headache, trigeminal autonomic cephalalgias, and other primary headaches. Let's examine one by one. Migraine is the commonest primary headache and is ranked 3rd most prevalent disease as per the Global Burden of Disease Survey 2010, and is the 3rd highest cause of disability worldwide in patients less than 50 years of age as per the GBD Survey 2015. It comes in 2 types, migraine with aura and without aura generally. So it follows a timeline. The first phase is the prodromal phase, which starts before the onset of aura or headache. During this period, the patient feels extremely tired, is unable to concentrate, he has excessively yawn, he can yawn excessively, he develops craving for certain food items, develops fluid retention and edema in the periorbital region, and the patient feels very tired. This is followed by the phase of aura, which starts about 5 to 60 minutes prior to the actual headache. During this period, the patient will have reversible symptoms of visual, sensory, or other types of aura. Then you have the actual period of headache, which lasts for about 4 to 72 hours, wherein you have unilateral throbbing type of headache, which might be associated with nausea, vomiting, photophobia, or phonophobia. It is followed by the phase of post-traumal phase or phase of resolution, which is usually has a duration of 24 to 48 hours, wherein again the patient feels very tired, loses the excessive fluid which has been retained, and again the patient will have sometimes will have a depressive mood. Now, how do you make a diagnosis of migraine without aura? To make a diagnosis of migraine without aura, the headache usually lasts for 4 to 72 hours. It has to be unilateral, pulsatile or throbbing in quality, of moderate to severe in intensity, and is aggravated by physical exercise. And it is usually accompanied by nausea or vomiting, photophobia, and phonophobia. And if the patient has 5 typical episodes and you are able to rule out other conditions, you can make a diagnosis of migraine without aura. In migraine with aura, the headache has exactly the same type as in migraine without aura, but it is usually associated with aura, which are fully reversible symptoms which affect the visual, sensory, speech and language, motor, brainstem, or retinal. These fully reversible aura symptoms are either positive or negative. For example, a positive visual symptom means a scintillating zigzag lines, or negative meaning an area where dark spots or scotoma in the visual field. Sensory, positive meaning tingling sensation, negative like can have numbness in the upper arm or in the perioral region. So exactly the progression is termed chiro-oral, where it starts from the upper limb and then extends to the perioral region. Usually, if you take aura, these symptoms develop gradually over a period of 5 minutes. And it's possible that the patient can have multiple types of aura. And each aura develops over a period of 5 minutes and lasts for about 5 to 60 minutes. That is, if a patient has 3 different types of aura, the total duration of aura symptoms is 60 into 3, that is 180 minutes or 3 hours. At least one aura symptom has to be unilateral, one aura symptom has to be positive, and is usually accompanied or followed by headache within the next 60 minutes. Again, it is a diagnosis of exclusion, and wherein you rule out other conditions causing the headache. So on the left side, you can see the scintillating zigzag lines, which resemble the medieval forts, hence called the fortification lines. And again, it can also present as a a dark spot in the visual field, which is usually homonymous. These are called scotomas. Now coming to the first case. A 56-year-old gentleman with diabetes mellitus, migraine with aura, had an episode of giddiness and headache and fall from bike 1 week back, and he sustained minor injuries. Presently, he is asymptomatic, except for a persistence of his visual blurring. So as we learned the previous slide, the maximum duration of an aura symptom is 60 minutes. If the patient has a persistent aura, always you have to suspect an infarct. As in this case, we suspected an infarct. We did a CT scan, we showed an occipital infarct. So when in the case of prolonged aura, always suspect an infarct. You can have several variants of migraine. Migraine with typical aura with headache, which need not fulfill the criteria of a typical migraine. Then you have typical aura without headache. Then you have brainstem aura, when the patient will have a history which satisfy the criteria of a migraine with aura, but the aura symptoms are brainstem symptoms like dysarthria, vertigo, tinnitus, decreased hearing, diplopia, ataxia, and is usually associated with a decrease in level of consciousness less than 13 of the Glasgow Coma Scale, with no motor or retinal symptoms. In hemiplegic migraine, it fulfills all the criteria of a migraine with aura, but will have fully reversible motor weakness, which usually lasts beyond 72 hours. The patient will also have other aura symptoms, which may be visual, sensory, or affecting the speech and language. You have familial hemiplegic migraine, which runs in families. Depending upon the genetic mutation, it is classified into 3 different types. It is as well possible that the patient will have a sporadic type of hemiplegic migraine, wherein you don't have any first or second degree relatives suffering from the same condition. You can have retinal migraine, wherein the aura symptoms are predominantly retinal, affecting monocular, unilateral, which is unilateral, fully reversible, positive or negative, and it has to be confirmed by clinical visual examination, or the patient should be able to draw the exact type of defect in the visual field. And as I mentioned earlier, it develops gradually over a period of 5 minutes, and symptoms last for about 5 to 60 minutes and is followed by headache. Again, you have to rule out other conditions. It's possible that the patient can have a chronic migraine. The patient will have headache for more than 15 days a month and continuously for 3 months like that. And he satisfies the criteria for migraine with aura or without aura. And half of the episodes, that is after 15 days, more than 8 days, the pattern exactly fulfills the criteria of migraine without aura or migraine with aura. And the patient can usually recognize such symptoms and takes ergotriptation or triptans in advance. So then you call it a chronic migraine. Now, what are different complications of migraine? You can have status migrainosus, where you have debilitating migraine with or without aura lasting for more than 72 hours. As I mentioned earlier, persistent aura for more than 1 week without infarction. Or you can actually have a migrainous infarction. Then you can have migraine aura triggered seizure, which occurs within 1 hour of an attack of migraine with aura. Then there are certain migraine equivalents like cyclical vomiting syndrome or abdominal migraine, where you have midline, periumbilical, poorly localized, dull aching pain of moderate to severe quality with anorexia, nausea, vomiting, pallor, and lasting for more than 2 hours and up to 72 hours. And the patient is up to absolutely normal in between. It's called abdominal migraine. Then you have benign paroxysmal vertigo, not positional vertigo, but benign paroxysmal vertigo, where you have sudden vestibular symptoms, which with spontaneous recovery, no loss of consciousness, and normal audiometric or vestibular test. And it's usually associated with nystagmus, ataxia, vomiting, or pallor. Then you have benign paroxysmal torticollis, especially in children, turning the head to one side, lasting for minutes or days, and associated with irritability, pallor, malaise, vomiting, ataxia, and the neurological examination is normal. This is also considered to be a migraine equivalent. Another equivalent is the paroxysmal orthostatic tachycardia syndrome, when you have a tachycardia when the child gets up from sitting position. Now coming to the next type of headache, the tension type of headache. So the type of headache is exactly opposite to what you have in a migrainous headache. That is, it lasts for 30 minutes to 7 days, and it's not usually 3 days. And the patients will have bilateral headache, which is non-pulsatile. It is mild or moderate in intensity compared to the moderate to severe intensity of a migrainous headache, and it's not aggravated by physical activity. The patient can have will not have usually nausea or vomiting, but can have either of photophobia or phonophobia. Again, it is a diagnosis of exclusion. Depending upon the frequency, it is divided into frequent, infrequent, and chronic types. If the patient's frequency is 1 every month, that is less than 12 every year, it is called infrequent. If the frequency is between 1 to 14 days every month, that is half of the days, it is called frequent. If the patient has headache for more than half of the days in the year, it is called chronic type of tension type of headache. Tension type of headache is usually a result of stress at work or due to academic pressure. And it's classified into two types, with or without pericranial tenderness. So we can have tenderness spots over the scalp or the neck muscles or the extracephalic regions. And this exactly similar because the mechanisms are exactly similar to what you have in fibromyalgia. So tension type headaches are classified into with or without pericranial tenderness. Now coming to trigeminal autonomic cephalalgias. This is a group with 4 different types of headache. One is cluster headache, paroxysmal hemicrania, Suna, and Sankt. But they have certain features in common. They are episodic, unilateral, severe headaches with stabbing or boring quality, and referred to the orbital, supraorbital, or temporal region, and will have associated trigeminal autonomic symptoms. What are the differences? Differences are mainly in duration, frequency, precipitating factors, and relieving factors. So there are 4 types of trigeminal autonomic cephalalgias. One, the cluster headache, paroxysmal hemicrania, then Suna, that is short-lasting unilateral neuralgiform headache associated with autonomic symptoms, and Sankt, that is short-lasting unilateral neuralgiform headache with conjunctival congestion and tearing. Now coming to the first type, cluster headache. So it is a severe type of headache, stabbing or boring in quality, and is usually felt in the orbital or supraorbital region or the temporal region, lasting for between 15 minutes to 180 minutes. And it has the following qualities like associated with conjunctival congestion or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead swelling or facial sweating, meiosis or and ptosis, and a sense of restlessness during the episode. Migrainous patients usually prefer to lie down and take rest, whereas in case of trigeminal autonomic cephalalgias, the patients are usually restless, and it's again a diagnosis of exclusion. Coming to the, again, it is classified into 2 types, episodic and chronic, depending upon whether the remission is less than 3 months or more than 3 months. In paroxysmal hemicrania, the type and distribution of headache is exactly similar as in cluster headache, but the duration is a little bit less, that is 2 to 30 minutes, and usually has a frequency of more than 5 or up to 40 per day. But the most important factor is how it responds to therapeutic doses of indomethacin. Again, it is a diagnosis of exclusion. Then you have come into short-lasting neuralgiform headaches. So again, the type and distribution is exactly similar, but the frequency is more. It can have up to 200 to 300 episodes per day, and it is very short-lasting, lasting for 1 to up to 600 seconds. It can have various patterns like a single stab, a series of stabs, or a sawtooth pattern where there is no relaxation in between. So what are the difference between Sankt and Suna? In Sankt, you have short-lasting unilateral neuralgiform headache attacks with both conjunctival congestion as well as tearing. Whereas in Suna, you have the same type of headache with either conjunctival congestion or lacrimation, never both. Again, this classified into episodic and chronic type, depending upon the duration of the remission. And coming to the second case, a 39-year-old doctor, a dermatologist, presented with features of sinusitis. He had a history of migraine of several years. But on taking a detailed history, we found that he had a recent change in character of the headache. He has severe stabbing type of headache, and pain is felt in the right frontotemporal region associated with redness and watering of the right eye and nasal block. During episodes which last for about 15 minutes, he becomes agitated and is unable to sleep. He even hits his wife and bangs his head on the walls. So when you have, we suspected a case as to be a case of Sankt. So when you have a diagnosis of Sankt, it is very important that you rule out conditions like a pituitary tumor, a skull-based tumor, arteriovenous malformations, and craniovertebral junction anomalies. So we did an MRI, and the patient in fact had a pituitary tumor. Now coming to the type hemicrania continua. It is exactly similar to paroxysmal hemicrania, but the duration is more than 3 months, and it responds to therapeutic doses of indomethacin. Again, classified into remitting and unremitting type, whether there is a, depending upon the period of remission, it is more than 24 hours or less than 24 hours. Now, comparison of different types of trigeminal autonomic cephalalgias. Cluster headaches and SUNCT are two conditions of trigeminal autonomic cephalalgia which are more common in males. The other types are more common in females. The type and severity of pain is same in all cases. It is severe, stabbing or boring in quality and is felt around the orbit, temple or the periorbital region. But what is the difference between all these four types is the duration and frequency of the headaches. In cluster headache, the frequency is very less, one every alternate day or up to 8 per day. Whereas in paroxysmal hemicrania, it is between 1 to 40 per day. SUNA and SUNCT, you have at least sometimes 200 to 300 episodes every day. And the duration in cluster headache, the duration lasts for 15 minutes to 180 minutes or up to 3 hours. Whereas in paroxysmal hemicrania, it is short lasting, lasts for a maximum of half an hour. Whereas in SUNCT and SUNA, it is very short lasting, lasts for a few seconds, between 5 to 240 seconds. And can be associated with autonomic symptoms and migraine symptoms which can overlap. And as I told you earlier, compared to migraines headaches, these patients are agitated during an episode. It is possible that the patient will have interictal pain in case of SUNA and SUNCT. Again, there are differences between the triggers. In cluster headache, it is usually triggered by alcohol and nitrates, whereas paroxysmal hemicrania is triggered by neck movements. SUNA and SUNCT are triggered by cutaneous palpation, cutaneous tender spots. Drugs of choice are also different. For example, in cluster headache, you can have drugs of choice are verapamil and lithium. In paroxysmal hemicrania, it is indomethacin, whereas in SUNA and SUNCT, the drug of choice is lamotrigine. Cluster headache usually responds to oxygen inhalation. As I told you earlier, if you have a case of SUNA or SUNCT, you should investigate for pituitary lesions and do a hormonal assay like melatonin, testosterone, cortisol, thyrotropin, and prolactin. And in case of persistent ptosis or suspect Horner syndrome, an imaging of the carotid arteries is very important. You can have other types of primary headaches. For example, it can be classified as those related to physical exertion. For example, those precipitated by cough, exercise, sexual activity, and another type called primary thunderclap headache, which we'll discuss later on. The second type is caused by direct physical stimulus. For example, a cold stimulus, patient taking ice cream or exposure to cold wind or sleeping in an AC room can trigger a headache. Then you can have external pressure type of headache, felt at the points of pressure, especially seen when the patient wears a helmet or when the patient has a new hairstyle called a ponytail headache. Then you have other types of headaches called epicranial headaches, which can be primary stabbing headache or nummular headache, where the patient says that you have coin-like spots around the scalp which has pain, and other spots are normal. Then you have miscellaneous types like hypnic headache, which is usually seen during sleep and is relieved once the patient wakes up. And again, you can have new daily persistent type of headache, where as I told you earlier, the patient can remember the exact date of onset of pain, will have severe pain right from day one, and it persists for more than 3 months, and other neurological and radiological investigations are normal. Now coming to the third case, a 39-year-old gentleman presented with history of biafrontal throbbing headache after sexual intercourse. This has been going on for the last 5 to 6 months, and headaches used to last for up to 2 days. He was started on beta blocker, but discontinued due to tiredness. Depressive symptoms did not get controlled with multiple antidepressants. The most important factor here is that the headaches which are distributed in the V1 distribution or the ophthalmic distribution usually responds to indomethacin. We started the patient on indomethacin, we had a dramatic response. Now, other primary headache, you can have a thunderclap headache, which has an abrupt onset, which is maximum intensity within 1 minute, lasts for more than 5 minutes. And you wrote other conditions, you make a diagnosis of thunderclap headache. So thunderclap headache type of headache you can have an intracerebral hemorrhage, cortical venous sinus thrombosis, vascular causes like a ruptured aneurysm, pituitary apoplexy, infective conditions like meningitis, colloid cyst of the third ventricle, or spontaneous intracranial hypotension or acute sinusitis, especially in case of barotrauma. It is always a diagnosis of exclusion. It is excluded by appropriate imaging and CSF studies. Then you have secondary headaches, which are symptoms, manifestations of an underlying condition, which is related to trauma, vascular, non-vascular, substance abuse or withdrawal, infection, disorders of homeostasis, and related to ENT and head and neck conditions. psychiatric disorders, neuralgias, and other unclassified types of headache. So as ENT surgeons, we are interested in item number 11. Now, what are the diagnostic alarms? So it is possible that a serious condition can, the presentation of a serious condition can mimic some common types of headaches. For example, headache which begins after the age of 50 years. A patient who has never had a headache suddenly has a headache. You have to think in terms of a temporal arteritis or a mass lesion, but can also happen in case of a tension type headache. Sudden onset of headache, always suspect a vascular cause like subarachnoid bleeding, pituitary apoplexy, or bleeding into a mass lesion. But it is also possible that the patient may have a primary excision type of headache. Accelerating headache, always suspect a subdural hematoma or a mass lesion, but it is also seen in case of medication overuse headache. Headache with fever, suspect a infective condition, meningitis, encephalitis, or cerebral abscess, but it is common in any infection, including COVID. Headache with focal neurological signs and symptoms, suspect a stroke, or mass lesion, or a vascular malformation, but it is equally possible that this can be associated with a migrainous aura. It can be a motor aura. Headache with papilledema, always think about a mass lesion in the brain, but it is also possible to have the same symptom in case of idiopathic intracranial hypertension or a pseudostoma cerebri. Headache associated with red eye, think of glaucoma, but it is possible that you are dealing, equally possible that you are dealing with a case of trigeminal autonomic cephalalgias. So coming to the next case, a 49-year-old gentleman who is a non-diabetic and hypertensive, post-PTCA, post-renal transplant, presented with fever, headache, vomiting, delirious behavior, and swelling right side of neck. On examination, he was conscious but confused. Vitals were stable, plus minus neck stiffness. Right level 2 lymph nodes were enlarged with mild inflammatory signs. Blood investigation showed only hyponatremia. Serum creatinine was marginal raised, that is 1.6. Radiology, ultrasound of neck was done, which showed a necrotic right level 2 lymph node, which was compressing the internal jugular vein. It was diagnosed, it reported as chorioinflammatory, choriometastatic. We did an MRI, which showed hyperintensity in the cerebellar vermis with hypointense hallux, possibly a cerebellar abscess or a lymphoproliferative disease. MR venography was done, which showed hypoplastic left transverse venous sinus. But the interesting fact was that during the rounds the next day, when I asked the patient different questions, he was giving the right answers, but he was keeping his face covered with his bedsheet. At that time, I remembered my professor, Dr. Haridas, who used to say that photophobia is a classical sign of TB meningitis. And we did an aspirate from the lymph node, it was AFP positive, started on ATT, and the patient had a total recovery. Now, cerebral venous sinus thrombosis. It can have 5 different patterns of presentation. It can present as isolated intracranial hypertension, that is progressive headache with papilledema, 6-nerve palsy, tinnitus, and blurring of vision. It can present as a venous infarction with focal signs, mimics a stroke, which can be chronic progressive like a tumor or an abscess. It can present as an encephalopathy with altered sensorium, focal neurological signs, seizures, and papilledema. Cavernous sinus thrombosis with frontal headache, chemosis, proptosis, and ophthalmoparesis, or a thunderclap headache, wherein you can have a sudden headache which then reaches a maximum intensity within 1 minute and continues for more than 5 minutes. You should always suspect a vascular cause and rule out a subarachnoid hemorrhage. Now, secondary cortical venous sinus thrombosis are seen in case of hypercoagulable states, cancer patient, and in autoimmune diseases. Now, coming to carotid dissection, it leads to presence with frontoorbital headache before ischemia. You can have a painful onus and a painful tinnitus, usually triggered by cough, sneezing, or trauma. And patient can have ipsinator neck pain or carotid bruit. The risks involved are more in case of syphilis or collagen vascular diseases. Medication overuse headache. It is possible that the patient might be taking analgesics for more than 14 days every month or triptans for more than 9 days per month. These patients are more prone to have chronic headaches, but usually associated with nausea. So when the patient has a chronic headache with nausea, all other conditions ruled out, ask about the medical pharmacology history, and the patient might be abusing analgesics or other relieving agents like triptans. Now coming to the 5th case, a 52-year-old gentleman was referred from cardiology to rule out fungal sinusitis. Why was a reference for fungal sinusitis? Because I had a case of fungal sinusitis and I had sent the patient for cardiology fitness. This patient had a right-sided throbbing headache with nausea. He had a history of migraine and he was under in considerable stress because he was a Pandal worker and was unemployed during this COVID times. This was a case sheet. He was he has history of CABG. He was a diabetic on insulin, and examination findings were not very marked. Plus, but a Corey right massive sinus tenderness. So I didn't even do an endoscopy. I gave some analgesics to this patient and asked him to report back after 2 days. If it does not subside, we will consider doing an endoscopy or imaging. After 2 days, he returned saying that the headache persisted or even increased in severity. Clinically, the ENT examination was within normal limits, and the clinical diagnosis was migraine. And to rule out intracranial causes, we did a CT scan. So as ENT surgeons, we are familiar with the CT of the PNS, which is basically normal. But just to make sure that I'm not missing anything, I called my radiology friend, Dr. Anjani, and she looked at the scan and said, the patient has a chronic subdural hematoma. It was promptly referred to the neurosurgeon. The patient underwent surgery and is doing fine after surgery. Again, it is very important to have a close friend in radiology whom you can depend on. Like this patient who presented to me a couple of days back. This 66-year-old lady came with severe right TMJ pain. She has severe pain while chewing, but also associated with headache. Just to make sure that I'm not missing anything, I did ask for a CT scan. This is the bone window, and it shows, by and large, it looks normal, but there is some abnormality here in the posterior fossa. So it is very important to examine the scans in the right window. So we looked at the scan in a cerebral window, which again showed a suspicious area in the posterior fossa. We asked for an MRI. A T2-weight MRI showed a big mass in the posterior fossa, and T1 weight image with contrast showed a big meningioma, which was causing a brainstem compression. So it is very important to do the right investigation and at the right time, and to get it interpreted by a person who is well versed in reading such scans. Now, I'm not going to describe in detail about sinusitis, acute and chronic, but as ENT surgeons, in this COVID times, we can have two different types of headaches. One, a de novo headache, which is related to the use of mask, and second, we should have a very high suspicion of COVID-associated mucormycosis when a post-COVID patient comes to us with severe headache. Now, coming to the final part of the presentation, to sum everything up, it is very important to have a headache diary. I asked my patients to keep a headache diary, which mentions the type of headache, the severity, time of onset, and how exactly he or she feels 1 hour before actual onset of headache, to look for, to understand the type of aura he or he is having, severity of headache associated with nausea, vomiting, bothered by light or sound. Is there a change in activity or limitation of activity? Exact duration of headache? What are the triggers and medications used? Now, how to go forward with the clinical examination? These are the points which can be done in a 3-minute clinical examination, of which 5 points related to the eye. Check the pupillary response, the eye movements, field of vision, corneal reflexes, and do a fundoscopy. Check the facial movements and ask the patient to protrude the tongue to look for any hypoglossal weakness. Check for palm drift, check for tandem gait and Romberg sign, and limb and plantar reflexes. Now, this mnemonic may be useful to remember the sinister cause of headache. The H stands for history, when you have the first and worst headache of his life, triggered by exertion, age more than 50 years, persists despite treatment, acute in onset, associated with CNS findings, associated with HIV or other immunocompromised states, and associated with fever. So this is a good mnemonic to remember. Another mnemonic which is useful is SNOOP. S stands for headache with systemic signs and symptoms or associated with systemic diseases. N stands for neurological symptoms or focal neurological signs and symptoms. O stands for onset and older age. P, change in pattern of the headache or in a patient with previous history of headache. So SNOOP is a very important way of remembering the sinister cause of headache. And finally, how to proceed in case of headache. When you have a thunderclap headache, which is new, abrupt, always think about subarachnoid hemorrhage. And what is the strategy? Ask for a contrast CT, MRI, or if negative, a lumbar puncture. Patient has an atypical headache lasting for more than 1 hour with motor symptoms. It could be a migraine, TIA, or stroke. How do you proceed? Take detailed history, get a CT with contrast or MRI. New headache in a patient more than 40 years of age, suspect temporal arteritis or exalt. Take a detailed history, do a blood test. You can have a high ESR and a CT with contrast. New headache in a prepubertal child, always think about posterior fossa tumors, and the investigation of choice is MRI. Headache associated with progressive headache associated with nausea, think of medication overuse headache, do a detailed neurological examination and withdraw the drug. Headache associated with physical activity could be migraine, and ask the patient to maintain a headache diary. Progressive headache with focal neurological signs and symptoms associated with change in cognition, suspect Nicsol, CT with contrast, MRI. Progressive throbbing type of headache associated with tinnitus and blurring, idiopathic intracranial hypertension, get an MRI and MRV done, and if negative and if normal, do a LP and record the opening pressure. Progressive headache in a hypercoagulable state with focal neurological signs and symptoms, always suspect cortical venous sinus thrombosis. Get an MR angiography and MR venography. Now we have several investigations at your disposal, CT, MRI, PET, blood investigations. But the most important tool in making a diagnosis is always the clinical history. Remember these golden words by William Osler, that is, listen to your patient, he is trying to give you the diagnosis. No, the take-home message is that always believe your patient. What he experiences he is telling you. So never unbelieve the patient, because he may say that the patient headache started after wearing a helmet, possible because it could be a primary headache, external pressure type of headache. Or a lady might say that headache started after her new hairstyle, could be again a ponytail headache. Now, what are the strategies? Reassurance and counseling are very important. Motivation for follow-up and prophylaxis. Maintain a headache diary. Identification and avoidance of triggers. Importance of non-pharmacological and lifestyle modification. Identification of red flags and timely reference. So at the end of history taking, if you are able to put together these pieces of the jigsaw puzzle together, you should congratulate yourself. If not, you should always refer to the concerned specialty. It is always important to refer. Thank you for your patient hearing, and I would be happy to answer any questions.
Thank you, sir. The forum is open for discussion.
Hello.
Hello.
Sir, do you do fundoscopy by yourself, or you?
No. I'm not at all trained in fundoscopy, because my ophthalmologist is next door. So I send the patient. If you want to refer to one specialist, always refer to the ophthalmologist, because he can examine for refractory errors, intraocular pressure, as well as he can examine the fundus. So the first referral should be to the ophthalmologist.
One more question I want to ask you. You didn't mention about the pharmacology.
No, basically my idea was not to discuss the theories or treatment options. My basic approach was to getting into the diagnosis. So what are the points to elicit in history and how to make a diagnosis? After that, you can always refer your textbooks for your diagnosis. But if you can ask me, I can give you the answers.
So in primary, in migraine, which is it's the prophylactic of your choice.
Usually, okay, let me see. Are you able to see?
Yes.
So
yes.
During acute episodes, you either give analgesics with or without antiemetics. It could be paracetamol, aspirin, or domperidone. Usually, I give naproxen with domperidone. Or sometimes these patients can respond very well to rizatriptan wafers. So of late, I have started using rizatriptan wafers, which gives me good result. And for prophylaxis, generally we start the patient on beta blockers, propranolol, 40 milligram once daily in sustained release preparation. If the patients are asthmatic, we start on other drugs like topiramate. Are you able to see?
Yes.
Topiramate or valproate. drug of choice for tension type headache is amitriptyline.
Hello.
Hello.
Unmute ചെയ്തല്ലേ?
Any more questions?
Hello, sir. When will you decide that this patient needs a neuro consult? Like you're treating the patient, he is responding, but you still feel that okay, this is the diagnosis, but patient is not happy.
Okay. So generally, going by history, if you are taking a detailed history, can get you the diagnosis of either migraine, tension type headache. When the patient shows atypical features, like the patient has the patient presenting with headache for the first time, he has never had a headache in his childhood, adolescent, or early adulthood, but later age group he presents with a severe headache. At that time, it is very important that you refer the patient to a neurosurgeon, neurologist. Then headache associated with fever, always letting go of meningitis. Then rapidly progressing headache, severe headache associated with focal neurological signs. Sometimes diplopia can be one important sign which can warrant a neurological referral.
Praveen, one question. Hello.
Yes, sir.
One question, Praveen. What regarding the status migraines? What is the ideal drug and simple drug in our practice?
So generally, I have not come across a case of status migrainosis. In such case, I would generally refer the patient to the neurologist.
Okay.
So in such cases, valproate is considered to be a very good drug. Oxygen inhalation might help.
Yeah. Okay. What about paracetamol and Dexona together?
I don't have any experience, sir, giving Dexona.
Paracetamol and Dexona together. That's all.
I don't have any experience, sir.
Okay.
More questions?
Sir,
Yes, sir.
Anand.
Hello.
Hello.
Sir, if it is one question, this is regarding sinusitis. If you diagnose a case of sinusitis acute, so which is the choice of the antibiotic of choice?
So as per our hospital protocol, we either start augmentin or cefuroxime. These are the two first-line drugs which have been recommended by our infection control department. And the duration of therapy is 10 to 14 days.
Hello.
Yes.
Sir, what about a patient presented with hypertension and headache, hypertension emergency?
Yes. So if the patient has got a very severe headache, very short duration, patient is a hypertensive, always think about subarachnoid hemorrhage. Always, it is better to refer the patient to a neurologist and get a CT with contrast, MRI, or a lumbar puncture.
Okay, sir. Thank you.
More questions?
Sir, one question. Is there any relation with steam inhalation and migraine? Because some patients say when they know, we know from history it's a case of migraine, but they say when they do daily steam inhalation, there is much relief. Is there anything really come across in your practice like that?
ഞാൻ മലയാളത്തിൽ പറയട്ടെ, കാരണം ഞാൻ ഇത്ര കാലം കണ്ടുവച്ച പേഷ്യൻസ്, മൈഗ്രെയിൻ പേഷ്യൻസ് പൊതുവെ പറയുന്നത് എനിക്ക് സാറ് ജലദോഷം വരാറേ ഇല്ല എന്നാണ്. എല്ലാവരും ധാരണ മൂക്കിനകത്തും സൈനസിനകത്തും കഫം കെട്ടി നിൽക്കുക എന്നാണ്. ആ കഫം പുറത്തേക്ക് കൊണ്ടുവരാനായിട്ടാണ് എല്ലാവരും ഈ സ്റ്റിമുലേഷൻ ചെയ്യുന്നത്. അതിന് സയന്റിഫിക് ബേസിസ് ഉണ്ടെന്ന് എനിക്ക് തോന്നുന്നില്ല. ബട്ട് ദർ ഇസ് നോ ഹാം. പക്ഷെ ഇപ്പോഴത്തെ കോവിഡ് ഒരു സിനാരിയോയില് എക്സസൈസ് സ്റ്റിമുലേഷൻ ഇസ് തോട്ട് ടു ബി വൺ മെക്കാനിസം which causes mucosal injury and increases the risk of getting a mucormycosis, invasive mucormycosis.
Hello.
Yes.
Sir, gross DNS ഉള്ള ഒരു പേഷ്യന്റിന് നമ്മളൊരു യൂണിലാറ്ററൽ ഹെഡേക്ക് ഉണ്ടെങ്കിൽ അതൊരു ഫീച്ചർ അതാണ് കാരണമായിട്ട് പറയാൻ പറ്റും സാർ. അതിന്
അപ്പൊ
സ്പെഷ്യൽ ആയിട്ട് എന്തെങ്കിലും
വെച്ചാൽ നമ്മൾ സ്ലഡേഴ്സ് ന്യൂറാൾജിയാണ് ഉദ്ദേശിക്കുന്നത് അതിന്റെ കോണ്ടാക്ട് പോയിന്റ്സിന്. അപ്പൊ അതിനകത്ത് പറയുന്ന വെച്ചാൽ there are other points in the body where mucosa comes into contact with mucosa which does not trigger any pain. അപ്പൊ ഒരു മ്യൂക്കോസ ടു മ്യൂക്കോസ കോണ്ടാക്ട് മൂക്കിൽ മാത്രം വരുന്നത് ഒരു ഹെഡേക്ക് ഉണ്ടാകുന്നത് ഈസ് അൺറീസണബിൾ എന്നുള്ളതാണ് ഒരു കോൺസെപ്റ്റ്. സെക്കൻഡ്, there are people who believe that Sledder's neuralgia occurs due to compression of the anti-ethmoid nerve, either septum or middle terminus. അപ്പൊ അങ്ങനെ സസ്പിഷൻ ഉണ്ടെങ്കിൽ ആ സൈഡ് മാത്രം സൈലോക്കിൻ വെച്ച് പാക്ക് ചെയ്ത് നോക്കുവാണെങ്കിൽ പെയിൻ റിലീവ് ചെയ്യുവാണെങ്കിൽ then you can take it as a positive finding and go ahead with your septoplasty or terminal reduction.
Okay sir, thank you.
If there are no more questions, we can wind up the session. Thank you, Praveen, Gopinath.